Okay, so let's get rolling. Good morning, everyone. Welcome. This is a special, not quite Grand Rounds presentation. And by way of disclosures, which we have to always start with, when you have disclosures, there might be food there, and that means there's no CME. So you have a trade-off. You either get CME and regular Grand Rounds, or you get food at a non-regular Grand Round. So today, our breakfast is sponsored by Alexion and Jeff McCann. Wave, Jeff. And Marisa Salinas. Wave, Marisa. Jeff actually has won 2 national chef competitions, and he spent all night working and making this food for us. And he did that in Marisa's small restaurant over in Dallas, and she let him use the kitchen there, but they drove it in this morning. So it's really, they've worked hard to get breakfast here for us. No, actually, none of that's true. So today we're going to talk about lysosomal acid lipase deficiency, and you're scratching your heads thinking, but Dr. Vanchiere, you're an infectious disease doctor. And that is true. And the way I've got involved with this disease and the development of a treatment for this disease is through clinical research study that we have been involved with here at LSU for the past almost 2 years. We actually have one patient who has lysosomal acid lipase deficiency. This patient was identified by Dr. McVie after a referral from an outside pediatrician. And not a few months after she was identified as having this disease, this clinical trial was available for enzyme replacement. And so this is one of many orphan diseases that we're beginning to see companies take an interest in, because the replacement enzyme is something that can significantly benefit patients. And of course, there's a financial incentive to do so. So you know things are going well for an orphan disease company when they bring you breakfast. So those are just the clues. Lysosomal acid lipase deficiency is our topic for today. And what I'd like to do is provide you an overview of the disease, a little bit on pathophysiology. Most importantly, talk about the differential diagnosis, because this is a rare disease, but it's one that you want to know about and keep in mind, and there may be others similar to it that can be confused with lysosomal acid lipase deficiency. So it's not a diagnosis you want to miss. And then we'll talk about clinical implications, because the presentations of this disease are extremely varied, and the manifestations are protean. So lysosomal acid lipase deficiency. Oh, let me go back one more step. All of these slides are FDA approved. They're not slides I made. They're not slides that I necessarily would have made. There's a lot of information on the slides, but I'll also highlight that information with our own experience, with our own patient. And slides from the FDA, approved by the FDA, are like bikinis, right? What they reveal is interesting, but what they hide is essential. So you have to look for what's not there. Okay? So lysosomal acid lipase deficiency, it's an autosomal recessive disease. It has 2 names in the clinical literature. One is cholesterol ester storage disease, which is its manifestation most commonly in children and adults. And so if you go into Epic and you're looking for something, you type in CESD and one disease comes up. It's amazing. In Epic, they only give you one option instead of thousands and thousands for cholesterol ester storage disease. In infants, the presentation has classically been known as Wolman disease, which we'll talk a little bit about. But these are 2 different presentations of the same enzyme deficiency. And when we get to the genetics, we'll also highlight that there's no way to tell from the genetics which of those 2 presentations will occur. As I said, this is a multi-organ disease. It primarily involves the liver, but long-term impacts the cardiovascular system, the spleen, and the GI tract. And we'll look at each of those 4 areas. In infants with the rapidly progressive fatal disease known as Wolman's disease, their average age of death is about 3.7 months. So from a pediatric perspective, you're thinking this is the timing of things like T-cell immune deficiencies, of overwhelming sepsis, of hereditary fructose intolerance, and a whole long list of metabolic things that can look really bad in the first few months of life. This is in that same differential. In the adult and pediatric later presentation, there is, about 50% of patients progress to fibrosis and or liver transplant within 3 years of symptom onset. And we'll talk about the symptomatology. But this is really one of the major things we're trying to avoid is patients needing liver transplants. This is the Kaplan-Meier curve of those babies with rapidly progressive disease. My pointer's not working. Let's see if this one works. There it is. And you can see that by 6 months of age, more than half have already died of this disease, and out to 12 months of age, about 90% have died with the rapidly progressive form of LAL deficiency. In the adult population, and adult and pediatric disease, here is time in years, and this is showing the event-free probability. So this is the timing of presentation, some manifestation, and about half have manifestations of disease by 3 years of age. So these are the kind of things you're going to be having to think about when you're doing those newborn exams, and those exams frequently during the first 2 years of life in our toddlers. This is one of those things that's in the broad differential. And here is the age spectrum of first manifestations. 39% of subjects in the largest case series reported presented at age 2 to 5 years old, but some patients don't have manifestations even out until their adult years, as late as 50 years or more. So it can present as an adult disease. All right, so what's happening? As I said, this is an autosomal recessive disease, and it is caused by mutations in the Lipase gene, which is on chromosome 10. What's fascinating is there are numerous different mutations that can lead to the same phenotype. So there's genotypic heterogeneity, but the phenotype is either going to be that rapid progressive in infancy or slow progressive in adolescence and adulthood. And the mutations are not predictive of which phenotype you will see. So that's a key thing, that even if you have genetic screening, you can't predict from the genetic screen whether the baby will rapidly progress or have a slower progression. And with the mutations that occur, there is little to no enzyme activity in the affected child. Now, what's also really fascinating is that patients who are carriers, either parents or siblings who inherit one bad allele, only have about 10% of the enzyme activity of an unaffected or non-carrier. Okay, so there's no, so it's easy to distinguish a carrier of the gene because they'll have about 10% activity. Despite having one good gene, you expect 50% activity. They only have about 10% activity of the enzyme, and the affected child is virtually none. So you have a nice spectrum of enzyme activity, and whether there is some heterozygote advantage is an important question. The allele frequency for these gene mutations is not well known. It's estimated to be 1 out of a few thousand, but we really don't have good data on the allele frequency, and whether there's a heterozygote advantage is not clear. And we can talk about that, offline, whether what my speculations would be. So the Lipase gene, or lysosomal acid lipase, basically helps get rid of cholesterol after it's already been used by the cell. So it's part of the degradation pathway. And when your lysosomal acid lipase doesn't function, you get accumulation of cholesterol and triglycerides in the lysosomes. And on the histopathology, there's a pathognomonic finding of birefringent cholesterol ester crystals in the liposomal compartments of the cells in the liver. And these accumulations, this graphically shows them. You could picture that as a bunch of viruses, right? But it's not really. It's just cholesterol. And ultimately, these liposomes get very large and swell and collect this cholesterol that the body's unable to get rid of. Okay? So it's a problem with getting rid of cholesterol waste in the normal metabolism. All right. So when you have this accumulation of lysosomal cholesterol ester and triglycerides, the common presenting symptoms, and the most common, are going to be hepatomegaly and splenomegaly. And those are the most common presenting symptoms. 90+% of patients, that will be the first finding on physical exam. Otherwise, they'll be asymptomatic. If you do liver enzyme screening for some reason, like they come in for a sepsis workup in the hospital and you happen to get a chem panel, you may see elevated AST and ALT. If you're doing your pre-adolescent, perhaps screening for cholesterol levels to look for familial cholesterolemia and other things, you may find elevated LDL and triglycerides as the only clue to a patient who has lysosomal acid lipase deficiency. And if for some reason they end up with a scope and because of GI manifestations of something, you may have an incidental finding of intestinal lipid accumulations in what are called foamy macrophages. So this is really the spectrum of clinical disease, and the places that we may see it are very nonspecific. Liver, spleen, elevated liver enzymes, elevated cholesterol, elevated triglycerides. And the combination of all of those together pushes you towards something like LAL deficiency, but by no means are any one of these pathognomonic. Okay? Ultimately, the downstream effects of these, fibrosis and cirrhosis, and I'll show you a couple of cases of progression of those over very short periods of time during pediatric years. Accelerated atherosclerosis and coronary artery disease, strokes as young adults are an important manifestation. Splenomegaly can be to the point of risk of traumatic rupture, of course, anemia and sequestration in the spleen, and then GI malabsorption, growth failure. So some of these babies will have failure to thrive as part of especially the rapid presentation. So let's go by organ systems. This says 86% have liver manifestations. I think most of the case series that have been reported say at least 90 to 95% have liver manifestations, most commonly being an enlarged liver, but those elevated liver enzymes. Cardiac manifestations, especially later because of the accelerated atherosclerosis. Large spleens, sequestration can occur, but is much less common, and GI manifestations are fairly understudied and probably occur more than we really know. They kind of take a back seat to more important things like a liver transplant and heart attacks in young adults. So in the liver, function is severely compromised as a progression over time, and the hallmark of this disease is microvesicular steatosis. You'll see patients who have a diagnosis of fatty liver disease, either non-alcoholic steatohepatosis or non-alcoholic fatty liver disease as their diagnosis, when ultimately they may have lysosomal acid lipase deficiency. And the progression to fibrosis and micronodular cirrhosis occurs over time, usually over years. Of course, portal hypertension and the end results of fulminant liver failure are what we're trying to avoid in the long term with these patients. And here's the microscopic. You can see micronodular cirrhosis. The liver of these patients is distinctly kind of orange-yellow color because of all the cholesterol accumulation. And you can see evidence of fibrosis here and all the scarring in the liver. And these are the cholesterol collections in the macrophages and the foamy Kupffer cells in the liver that are seen on biopsy. So in the largest case series, which included over 135 patients, the youngest evidence of microvesicular disease in the liver was at 17 weeks of gestation, so in utero, and the median first age of manifestations was right about 5 years, as we said before, and disease progression or death due to liver disease progression can occur or has occurred as young as 7 years of age. So fairly rapid course. 50% of the deaths were with liver disease were due to in patients under 21 years of age. So the presentations are going to be primarily pediatric and adolescent for the more fulminant courses. In another study of observational study, elevated liver enzymes were identified in 92% of patients. Evidence of cirrhosis or fibrosis in almost 2/3 of patients. And in those less than 18 years of age, 85% already had fibrosis and cirrhosis. Okay. All right, so here's a kind of a case example. Here's a pediatric patient who at age 5 was found to have hepatosplenomegaly, adrenal gland calcification, which is another hallmark of this disease that can be very instructive, and elevated cholesterol, triglycerides not so bad. The baby was started, or the child was started on simvastatin and cholestyramine, a low-fat diet, and you can see that the symptoms improved, and this baby actually had LAL deficiency confirmed early at 5 years of age. However, by 8 years of age, hepatic fibrosis had worsened, and then portal hypertension, and ultimately this child required a liver transplant by age 10. Cardiac manifestations. I think these are fascinating slides. You can see these are the bones of the spine. And here are calcifications throughout the aorta in the ascending, descending, and all the way down into the thoracic aorta, significant calcifications associated with lysosomal acid lipase deficiency. Those may almost be pathognomonic for this disease as well. So patients with cardiovascular manifestations have dyslipidemia with elevated cholesterols, low LDLs, low HDLs, and the accelerated atherosclerosis and coronary artery disease, myocardial infarction, aneurysms, and strokes in late adolescence or early adult years. In this study of 49 children and adults with LAL, their mean LDL level at baseline was about 200, and I'll show you another graphic of that, how it compares to other fatty liver disease in just a minute. 81% were taking lipid-lowering medications, and 20 of the 49 patients, so not quite a half, received their first lipid-lowering medication before age 18. So when you're doing those cholesterol checks in your general pediatrics clinic and you see one that's out of range, you know you're going to go through an algorithm and say, okay, is this just familial? Is this fatty liver disease? Or is it something else? And in the something else category is a disease like LAL deficiency. Okay. And then in terms of comparing genotypes to phenotypes, here's a group of 55 genotyped patients. 4 patients had hypertension, so adolescents and young adults with hypertension, and 2 patients in the mid-30, mid-40 age range with strokes, earlier than they should have them by cardiovascular disease. Splenic manifestations, we talked about splenomegaly. Here's a great case in the operating room of a huge engorged spleen. Here's an infant who had rapid progression of abdominal distension. You can see over 24 days there. And and so the problems with hypersplenism, thrombocytopenia, and anemia, and of course the potential consequences we're all aware of with splenectomy and its consequences, and traumatic rupture of the spleen, which for this size spleen, my guess would be rapidly fatal. In the GI tract, again, an underappreciated disease, but these patients often have abdominal and epigastric pain, emesis, gallbladder dysfunction, diarrhea, GI bleeding, malabsorption. So what does all that sound like? Inflammatory bowel disease. You've got a lot of crossover with other diseases that we see manifest in adolescent period. And on biopsy of the GI tract, you can see these collections of cholesterol in the histiocytes of the intestinal villi. And those are a big tip-off that this may be lysosomal acid lipase deficiency. Again, it's the inability to get rid of old cholesterol, and that old cholesterol accumulates in different cell types. So the options currently available for lysosomal acid lipase deficiency are conservative and supportive management, low-fat diet, statins, and other lipid-lowering agents. Of course, we want to avoid liver transplant and stem cell transplant if we can, because those have a lot of morbidities and mortalities associated with them as well. But these supportive therapies really don't address the underlying pathophysiology of the disease. And until recently, there have not been any enzyme replacement available to hopefully change the course of disease for these patients. So here's another case example. This is a pediatric patient at 2 years of age, had pneumonia and measles and had a big liver and spleen. She was on some cholestyramine intermittently for the next 5 years, found to have lipid-filled histiocytes in her bone marrow, cirrhosis, and progression of hepatitis. Duodenal biopsy showed foam cells in the lamina propria at 8 years of age. So still scratching their head because we haven't made a definitive diagnosis. And finally, at age 11, she was confirmed to have LAL deficiency. She had persistent anemia and occult GI bleed, developed pulmonary hypertension by age 15, and had a stroke. By age 18, she had progressive disease and ultimately became comatose following a generalized tonic-clonic seizure and died 2 months after hospitalization. So a course of disease that we definitely would like to try to avoid. This was in the era when there really were no options for treatment of this disease. And we're not going to talk about treatment today in terms of the formal presentation. We'll have a few comments about that afterward, after the cameras are off or whatever. So your differential diagnosis. Here's the age distribution in purple of patients who've been diagnosed with LAL deficiency. And you can see that the predominant time of diagnosis is in the adolescent and young adult years compared to the spectrum of the general population. And so it kind of begs the question, if we're diagnosing them here, what happened 10, 15, 20 years ago? The likelihood was that these patients died of undiagnosed LAL deficiency, and that's why you don't see patients with LAL deficiency surviving out into their 40s and 50s. So a family history of early adult death may be the only clue you get to some trait here. But again, it's autosomal recessive, not likely to run in families in particular, okay? So it's not a dominant gene. So it's going to be more likely to show up in a non-familial kind of situation. You won't have a family history. You'll be taking that history for other reasons. We talked about the liver abnormalities, and this really kind of points you to when to suspect LAL deficiency. Liver abnormalities in combination especially with elevated liver enzymes and a patient who's had a diagnosis of non-alcoholic fatty liver disease or steatohepatosis with elevated liver enzymes despite weight loss. So the weight loss doesn't resolve the fatty liver disease. That may be a patient with LAL deficiency. Wilson's disease is fairly rare, but it can overlap here, especially in patients who you suspect Wilson's disease, but they don't have CNS manifestations. Or other patients with symptoms that are unexplained, cryptogenic cirrhosis or hepatomegaly of unexplained etiology, hepatic steatosis, with especially on biopsy showing these microvesicular steatosis. Liver and lipid abnormalities together, ALT elevated, and especially with dyslipidemia. Here you go, our metabolic syndrome. You suspect familial hypercholesterolemia, but the patient also has elevated liver enzymes. That would be a good kind of case to begin thinking about LAL deficiency or other alternative diagnoses than your familial hypercholesterolemia. All right, so this breaks it down one by one. We won't spend a lot of time on these, but liver, unexplained liver disease, if you get virologic and immunologic testing that rules out all the common things. So we had a patient in clinic just yesterday, an 11-year-old with fibrosis of the liver and acute elevation in liver enzymes over the past month. Jaundice, it's beginning to resolve. He's getting better. We asked, okay, does he also have with that elevated cholesterol or elevated triglycerides? And for this child, he didn't. But that's sort of the typical, or one of the typical courses that or times you might think about something like LAL deficiency. We don't have a good explanation for his liver disease. Maybe it's an underlying metabolic defect. Wilson's disease, you'll see more likely on the boards than anywhere else. But remember, it's a difficulty with copper metabolism and accumulation of disease in the brain and the liver. And what do you call those little circles in the eyes that they have? Kaiser-Fleischer rings? Yeah, right. You'll see those on the boards too, right? Okay. Liver abnormalities, as I said, non-alcoholic fatty liver disease and steatohepatosis with elevated liver enzymes despite weight loss. You may look at the break points for cholesterol in adults and pediatrics and consider whether they may have lysosomal acid lipase deficiency. So the progression to fibrosis may help distinguish LAL from non-alcoholic fatty liver disease. The vast majority of patients with non-alcoholic disease of the liver don't progress to fibrosis. They will continue to have improving or stable disease over time, about 2/3. And the progression to fibrosis, if it does occur, is over many, many years, so much longer than you typically see in LAL deficiency, down the course of 5 to 7 years. Here's the mean cholesterol levels in patients with non-alcoholic fatty liver disease here in yellow, and a separate study, that's pediatric in yellow, adult studies in this kind of bluish color, and patients with LAL deficiency at baseline. You can see those cholesterol levels were significantly higher in the patients with LAL deficiency. Now you don't have error bars here to compare it. You're looking at a difference of about from 200 down to 120s, 130s, 150s. Okay, so it may be kind of gray. You're scratching your head, but if you see it higher than you expect for typical fatty liver disease, think possibly LAL deficiency. And I think probably the most compelling case to think about LAL deficiency is when there are both liver and lipid abnormalities, elevated liver enzymes and high cholesterol plus high triglycerides. The metabolic syndrome, much less common in children, but we are seeing more of it in endocrine clinic and with our type 2 diabetics, an obesity epidemic in children, and that may mask the symptoms or may be a presenting symptom of LAL deficiency also. Hypercholesterolemia that's familial with elevated liver enzymes, again, suspicious for LAL deficiency. All right, how do we make the diagnosis? The diagnosis is done by enzyme-based blood test, so it's a dried blood spot. That can be done on whole blood or it can be done on subsets of cells, but whole blood is the easiest. There are several centers around the United States that do this test. It's very inexpensive and, well, fairly inexpensive in the big picture of things, and it takes usually about 2 weeks to get the results back. But it's very good. You can go to genetic sequencing of the lipogenes, but that doesn't change your management. That doesn't change your diagnosis. And because of the whole broad spectrum of mutations that are associated with disease, have any duct tape? Because of the broad spectrum of mutations that may be associated with this disease and the possibility that there are still mutations that haven't been characterized, the enzyme-based test is the best and the most important one. Sorry. Liver biopsy, while it can have pathognomonic features by itself, is not always diagnostic of LAL deficiency, and so that's really not your test of choice to make the diagnosis. Go straight for the blood spot. It's much easier on the patient. And the interpretation of those blood spots, they're going to tell you either affected, and that confirms the disease, indeterminate, which you want to repeat, or normal, and that rules out the disease. It's both sensitive and specific, using the cutoffs that are available. All right, so what are the clinical implications? We've reviewed these already. Kaplan-Meier curves for survival in the rapid presentation in infancy and the presentation of symptoms in the adolescent and adult group. 50% have symptoms of some sort by age 3. And that may be only your physical exam findings of hepatosplenomegaly. So ultimately, over time, this disease is life-threatening because of especially the cardiovascular and hepatic manifestations of the disease, and that's ultimately what we want to prevent. While it is a rare disease, probably about 1 in 300,000 or 250,000 live births will have this disease in the United States. What that means is somewhere around 10 to 20 babies a year in the United States are born with LAL deficiency, as best we can tell. There's a lot of information we don't have on the allele frequency and the epidemiology. This is not a disease that's yet on the radar for newborn screening at this time. The company that is sponsoring our talk, Alexion, has both patient support information and for education support, as well as for physicians, as well as an LAL registry to identify patients who have this disease. What is sort of the punchline for all of this is that Alexion now has an FDA-approved enzyme supplementation that is approved for use in patients with LAL deficiency. It's a great story. Someone actually took a good lipogene, cloned it into a chicken. They made a transgenic chicken. And every time the chicken lays an egg, they capture that golden egg and they isolate the enzyme from the egg white, purify it, squirt it into the veins of the patient, and you've replaced the enzyme in the blood. Did I get that right, Marissa? Okay, good. So this is a fairly novel way to do this. It's fascinating. Other rare diseases, Pompei's disease, have enzyme replacements, and we've done some of those studies here at LSU and had patients who've received those enzymes. In this case, the drug was FDA approved within the past 6 months ago, right about, somewhere in there. 3 months ago. Ooh. Seems like a long time. And will be available for patients with LAL deficiency. Now, who's going to pay for it, what the cost is, those are good questions. It's probably not going to be inexpensive. However, when you avoid a liver transplant and heart disease, then you've got to weigh those risks and benefits. And for the patient that we had here. Let's finish this so now I can talk. The patient we had in our research study here actually received replacement enzyme for about 15 months, and she did quite well with the enzyme replacement. There were no safety issues identified. She had infusions every 2 weeks. It's a 1 hour long infusion, and we of course were hyper intensive monitoring for safety and side effects, also looking for anti-drug antibodies and other things that could potentially occur. And our patient's liver enzymes came back into the normal range. Her cholesterol levels came near to normal range for her age over the course of that year, and her liver biopsy actually improved compared to the beginning of the study. After a year, her liver biopsy was improved, and the size of her liver was significantly less than when she started. So in terms of the hepatic manifestations, our N of 1 experience has been very good with enzyme replacement, and the broader studies around the world, I believe there were less than 100 patients in the study who received this enzyme, but was enough to convince the FDA that for an orphan disease with long-term life-threatening manifestations, that the approval was appropriate for this enzyme. So that's the end of the story on lysosomal acid lipase deficiency. I think it's a kind of a fascinating story, and I'd be happy to take any questions. Dr. Premature.
That was a fascinating presentation. I didn't know much about this disease. Two things.
Wait, did you guys hear that? He said he didn't know much about this disease. So that means he learned something. So he might get some CME credit. See? Okay. All right.
Yeah. So 2 questions. I know Francis Collins is collecting blood all over the world. He told us at the national conference for orphan diseases. So is this one of the diseases, because we don't know whether there's an ethnic predilection
right.
for this particular disease, unlike other storage diseases which we know
right.
Has originated in certain ethnic groups in Europe or other possible.
So Dr. Premature's question is, Francis Collins, who's the director of the National Institutes of Health, apparently is going around the world collecting blood, so be careful if you see him. And the goal is to try to use the molecular technology we have available through the Human Genome Project and other things to ask how common are diseases like this, and how frequently can we pick up the mutations that are pathogenic as opposed to just allele differences that don't impact pathogenesis. So, and particularly Dr. Premanic's worried about ethnic predilection. This disease doesn't have a particular ethnic predilection that's been described. And worldwide, there are about 250 cases of this disease that have been either reported in the literature or data accumulated from, and they're globally distributed, and there's not an ethnic distribution, or ethnic predilection, I should say. So it should be on the radar for those kind of studies and identified in the Human Genome Projects, and it probably will accelerate a little more quickly because there actually is a treatment for it that can significantly impact health. So, good question. Dr. Koo.
That was very nice, John. One of the slides got ectopic calcification aorta. Now I can think in terms of mechanistically, presumably atherosclerotic plaque and things. But am I missing things on that slide with the 2 pictures? And one of the top one, the vertebral column seems to be a bit more sclerotic. Is there any problems there? It's not a normal looking vertebrae.
Good question. Are those normal looking vertebrae? I thought they looked a little funky too. There. Yeah, I agree with you. Those are definitely abnormal looking vertebrae over there. And it may be that this patient has had some surgery. I don't know. Good question. That's definitely abnormal back behind there. These look a little more normal. Yeah, I agree with you.
Have a look at hypophosphatemia.
All right. Other questions? All right. Thank you. We want to thank Alexion for providing breakfast, and keep up the good work.